Yeah, it's a pleasure to have everybody on call, and I'm excited that today's meeting is going to be one that would enlighten us more on the.
On the
Um, why am I getting a
What am I
feedback?
getting in feedback?
Sorry, can you all hear me?
Yes, sir.
Yes, sir.
All right, so we expect that today's meeting will be one that would enlighten each and every one of us and also tell us more about the peculiarities of breast cancer among Africans and among Nigerians, and then how we can help to mitigate the impact in quality of life of our patients. So I will call on behalf of the board of directors and on
Director.
behalf of all the members of Oncology Nursing Society, I would like
I would.
to express sincere gratitude to everybody who is on this call and also sincere gratitude to our speaker for today. So I will call the Vice President, VP Fatima Adam, to introduce our speaker to us, who is going to really enlighten us today. So we are really we are excited. Yeah, Fatima, over to you. I think you're muted. We can't hear you. Okay, let me. Yeah, just give us a second. I think she's addressing some technical issues.
Hello, am I audible now, please?
Yeah, we can hear you.
Okay, good evening, everyone. I'm Fatima Adam, and our presenter for today's event is Dr. Olubukola Ayodele. Dr. Olubukola Ayodele is a consultant medical oncologist at the University Hospital of Leicester, NHS Trust, UK, who specializes in the management of breast malignancies, that's breast cancer. She's an honorary senior lecturer at the University of Leicester and the head of breast cancer units at Leicester's Cancer Research Center, also leading the breast cancer clinical trial portfolio. She obtained a dual fellowship in drug development and sarcoma from the Princess Margaret Cancer Center, that is in Toronto, Canada. And following Dr. Olubukola's specialist in oncology training in the Republic of Ireland, that's interesting. She is the inaugural recipient of the ISMO PMCC Collaboration Fellowship Award in 2018. She is also a recipient of the 2021 ASCO Conquer Cancer Endowed Merit Award. She is the author of multiple publications, including a book, chapter, and serves as a reviewer for several scientific journals. Dr. Ayodele also has a portfolio of academic and commercial clinical trials, which she runs alongside collaborative translation research projects focusing on molecular drivers and biomarkers in breast cancer. She has received multiple grants for her research work. That's interesting. So Dr. Olubukola, she is a very passionate oncologist. She is passionate about global oncology. She has a postgraduate diploma in global health education from the University of Toronto and is an alumnus of the Global Oncology Leadership Development Program in PMCC. That's Princess Margaret Cancer Center in Toronto. In order to facilitate collaboration and advocacy of cancer in low and middle income countries, that's like Nigeria and some other African countries. She's on the steering group of the London Global Cancer Week and organizes the Friday in-person meeting. She's an active member of UK and Ireland Global Cancer Network. She's a trustee of the British Nigerian Oncology Group of Hope Arise Charities. She sits on the tumor board of many cancer centers in Nigeria, helping in the management of cancer patients in a multidisciplinary fashion. Dr. Ayodele also has interest in reducing inequalities in the UK and Europe. She sits on Breast Cancer Now Inequalities Funding Committee and the European Cancer Organization Inequality Network, contributing to the health policies. She has been actively involved in several projects involving breast cancer in Black women. She recently launched the Ebony Experience with Cancer, a platform for Black people who have been affected by cancer with the aim of increasing awareness and educating the public in order to reduce the poor outcome in cancer among the Black populations. She's involved in several charities and NGOs in the UK and Nigeria in organizing educational programs, research, and capacity building workshops. So Dr. Olubukola is a member of ASCO, ESMO, ACP, UKBC, and IOTIC. So Dr. Olubukola, welcome on board, Ma. Thank you.
Thank you for the fantastic introduction. I think you've done my first two slides already, so well done. Thank you. I want to say a big thank you to Chinomso for inviting me here. And today I plan it to be very interactive. So I don't have a lot of slides because I want to hear from you guys what you think about breast cancer and why it's a big deal in Africans. So I'm just going to share my slide and give me a second. Let's figure this out. So, yeah. Can you see my screen?
Yeah, we can see it.
Okay, perfect. So, like I said, it's going to be interactive, and basically, we really want to know about breast cancer and why it's such a big deal and so difficult among Africans and what's peculiar to us. Okay. So, you guys have done all of this. So this is just my background to say that I actually started from Nigeria, went to medical school, University of Lagos, Idiaraba, and then went off to Ireland to do my internal medicine and medical oncology training before moving to Canada. And now I'm in the UK. I wear many hats, as you would have figured out. My main duty is being a medical oncologist that manages breast cancer, but I do a lot of things in clinical trials. I'm also involved with education. So, University of Leicester, I'm a honorary senior lecturer, but also I do a lot of research and I have become a telemedicine slash health educator by starting up a YouTube channel called The Ebony Experience with Cancer. So I basically am a big global oncology advocate where I try to make sure that we reduce disparities and outcomes in people generally. You know, I usually say where you live should not determine how you live and your outcome. So that's what I do. So I really want to know you guys as well. So who are the people in the room? I think we have. So because I'm sharing my screen, I can't see everyone again, but I think the last time I checked, we had about 31 people in the room. So I don't know if the numbers have gone up or gone down since, but where's everybody from? What part of the country are you from? Just out of curiosity. You guys can unmute yourself if possible. I just wanted to know who are the people in the room.
Okay. Good evening, Dr. Ayodele. Good evening, everyone.
Good evening. Good evening.
Okay. I am Olawunmi Olayoye. I'm a perioperative nurse in Lutz. I reside in Lagos, Nigeria.
Okay, welcome. I can see someone said they're from Ebonyi. Was that Chizoba? Okay, and then
Yeah, greetings, Chizoba from Ebonyi.
nice to meet you. Nice to meet you. Most people are from Lagos, so it's good to see someone from Ebonyi. Anybody outside Lagos?
Greetings, Nurse Eze Patience from Ebonyi.
Oh, nice, nice. And our VP is from Castina. Wow. Okay.
I'm Bakari Abosede from Lagos as well, a student of Babcock University.
Welcome, welcome. And then someone is from Abeokuta, Pokuola Olajumoke.
Good evening,
Okay.
everyone.
Good
everyone.
evening. Good evening.
I'm Nurse Adedayo from National Hospital Abuja,
Oh,
Nigeria.
wow. Nice, nice. Brilliant. So we have so many
And I'm
people.
from Georgia.
Oh, yes, Chinomso. Thank you. What time is it in Georgia?
It's 12:13 p.m.
Okay, fair enough. It's not like something weird like in the middle of the night.
Yeah,
So,
no.
okay. So you guys can put where you're from in the chat and we'll look at it as we go on. So, just because of time, we'll kick on. So basically today we'll be talking about breast cancer in Africa, the statistics. Like I said, why is it a big deal in Africans? What are the unique barriers that we face? The role of oncology nurses, some success stories and potential opportunities, and then we'll go through a case study. And then I really want to talk about advocacy and the power of nurses when it comes to advocacy, and then obviously call to action and conclusion. So throughout today, we'll be trying to understand the unique characteristics of breast cancer, explore some of the disparities that we see, discuss some of the cultural and social systemic barriers to care, and obviously strategies that we can help to improve these outcomes. So as part of introduction, we have to talk about what breast cancer is. I know that I don't want to assume that everybody has a knowledge of breast cancer because even though it's the most common cancer worldwide and the leading cause of death in Black women, a lot of people might not know what breast cancer is. So, breast cancer is basically abnormal cells that develop from the breast tissue. And the breast tissue is full of fat mainly, and those fat would drain into something called lymph nodes. So if we take a look at the picture on the left side, you can see that in this yellow bit, which is the fat, you can have multiple lumps. So having a lump in your breast does not mean it has to be cancer. However, we don't know until we check it out. So that's why every lump should be checked out. And what makes a benign lump different is what we call the invasive or infiltrative picture. So if you look at that little lump in the bottom, you can see that it's sitting nice into that yellow fat, which is, and is well circumscribed. But if you look at the one which is on top, which is the cancerous, you can see that it's invading into surrounding structures, into the blood vessels as well. So that's what makes the lump different, a cancerous lump different from a benign lump. And where it comes from also matters. So the breast in itself was mainly made for milk production. So you have the lobe where the milk starts from, and then it drains into the duct and then comes out from the nipple. Okay. And if the cancer develops from the lobe, then it's called lobular cancer. But if it comes out from the duct, which is the small tubes that you can see here, then it's called ductal. Ductal cancer is the most common, so it's 70% of the cancers we see is ductal. And because you can see that the tubes are very thin, that's why we tend to feel a lump or we can palpate a lump if it starts to grow abnormally. However, lobular cancer, because it's in the lobes, it can infiltrate. So it's not every time that it has to be a lump. So that's one of the things that I want everyone to learn today. You can have breast cancer without a lump developing, because if it's coming from the lobes or if it's a lobular cancer, then it doesn't have to have a lump. It can present as a rash, it can present as swelling all over, and that's why most of the time with lobular cancer, we need to do an MRI to actually know the extent of the cancer, which is different from ductal cancer. So just be aware, and that's one learning point for today. So when we talk about the breast cancer in Africa, what are the statistics? We know that Black women have a higher mortality rate compared to white women, despite the fact that white women have more cancer incidence. So you will find more breast cancer in white women. However, globally, everywhere in the world, Black women die more from breast cancer. In Africa, we are seeing an increasing incidence of breast cancer. One, we feel like a lot of it is due to lifestyle changes and urbanization. But second one is the fact that people are becoming slightly more aware. So we're having more diagnoses, meaning that our incidence is increasing. In terms of mortality rates, we know that in Africa, there are higher mortality rates. And if we look at the 5-year survival rates of sub-Saharan Africa compared to Europe and US, we're looking at such a big disparity, 40% or less compared to 90%. This is crazy, basically. So imagine that the fact that a white woman in Europe or in America has breast cancer, her 5-year survival rate is in the 90s, yet someone who is in Nigeria has less than 30% of survival. And that's why breast cancer has been synonymous with death. And when anybody hears breast cancer, they're so afraid and they think they're going to die because of this mortality rate. So when we look at the incidence rate, we're talking about 28,000 new cases annually in Nigeria. And breast cancer accounts for almost 1 out of 4 new cases of cancer seen in women. And it's like 100% increase from the previous decade. So there is a rise, but also the mortality, we're talking about one of the highest in the world when we look at the burden of breast cancer in Nigeria. So why is this a big deal in Africans? The first thing is the biology, okay? So we tend to have more aggressive subtypes of breast cancer called triple negative breast cancer, okay? And it's prevalent in our world to about 20%. Also, breast cancer is diagnosed in younger ages compared to the Western population. Like it was mentioned, like Fatina mentioned, I sit on tumor boards of many cancer centers in Nigeria. And in the last 2 years, I can count the number of women who are above 60 that have breast cancer. Like most of the women that we're seeing are 40 or less, so this is becoming a big, big problem. Also, the late diagnosis, 70% of cases in Nigeria are diagnosed at stage 3 or above, so stage 3 or 4. And once you pass that stage, let's, if I pull back slightly. So if someone is diagnosed with stage 1 breast cancer, their survival rate is about 98%. If they're diagnosed with stage 2, the survival rate drops to about 70 thereabout. By the time they get to a stage 3, the survival is dropping to the 40s. And by the time they're stage 4, obviously, survival is coming into around 20 or less. So imagine that 70% of patients in Nigeria are being diagnosed with stage 3 or 4. Also, because there are no national screening programs like in the UK or in America where women are being invited to come for screening programs, it means that a lot of times women are presenting very late. Also, the treatment gaps. We don't have access to advanced treatments like targeted therapy. It was only recently that even things like Herceptin or trastuzumab became available, and there's still a lot of targeted therapies that we can get, despite no matter the money you have, it's just not even available. So it's a big deal that pharma is still not coming to Africa as we expect them to. Also, the very poor health infrastructures in many regions of the country. So someone who is in Lagos has a higher chances of surviving than someone who is in Castina, just because of this infrastructure that is there in many regions. So how does breast cancer present? Like I mentioned earlier on, the most common thing you would find would be lump, but it can present without lump. You can have a discharge, you can have nipple changes where the nipple goes in called nipple inversion, you can have dimpling, you can have changes to the skin, so rash or inflammation or swelling all around, that's a possibility. And if you find the lump doesn't always have to be in the breast. It could be in what we call the breast tail, underneath the arm. It could be in the neck. It could be a lump underneath the arm itself, in the axilla or underneath the armpit. And then you can have it quite late. A lot of women in Africa, I'm seeing that more and more. They're presenting late where you're having things like this, where you have ulceration, you're having patients coming like this. And it's funny that that mentality does not stay with the fact that you're in Nigeria. Even Nigerians abroad are presenting like this. So I'm going to show you, the next picture I show you is a lady who is 42 years old. She is a university lecturer here in Leicester, and she has presented like this. So you cannot tell me that this woman did not know that she had breast cancer. She's 42. She's a single mother with 2 children. And now she has metastatic disease everywhere. So it's funny that this mentality of not coming out quick has sometimes have nothing to do, and I'm sure Chinonso will see the same, where in the States, despite being in the States, people are still presenting so late. So what are the unique barriers that we're facing? Lack of awareness. A lot of women in Nigeria are even unaware of what the symptoms are. If you pick a random person by the road, they don't even know what to look out for. And I'll talk about where nurses come into that. So there's a lack of awareness. There's also a lack of what factors or risk factors that might be associated with breast cancer. I didn't go very deep into, because I want to focus on how we can help, but there are a lot of risk factors that people don't think about. So one of the things that a lot of people don't think about now is alcohol. So alcohol has become one of the biggest risk factors for breast cancer. Also, sedentary lifestyle, overweight. These are all big side effects or what we call risk factors associated with breast cancer. The other thing is the stigma. There's so much stigma. People are just so afraid of cancer. Once you hear the C word, they just think it's a death sentence. Also, some people think it's a from spiritual causes, voodoo, and then when they do know that something is wrong, there's so much belief in traditional or faith healers over medical care. So they would have gone everywhere else before actually coming to see you. And by the time they come to see you, it's usually very late. Number three is one of the biggest things as well, the financial constraint. The fact that there's no national screening services, people have to pay out of pocket for even screening services such as mammography, also paying out of pocket for treatment, and the cost of cancer care is high. Anywhere in the world, it is high. A lot of the governments are actually putting a lot of money into cancer care. And obviously, Nigeria, lack of insurance or financial support. Gender dynamics as well. Breast cancer is something that affects women. So women actually would prioritize their family needs over theirs, which also a lot of women, depending on which part of the country, they have limited decision to make limited decision making power in some cultures. So, for example, in the North, women can't present until their husband allows them. In some cultures, in some faith, and all of that. Also, a woman would be like, "Oh, I need to." They might be the breadwinners in the family, so rather than be sick in quote, they will just push ahead. They know they found something, they will leave it until the very end. Also, the fact that there is underrepresentation in research makes some of the treatment even available a bit difficult. So I see that when it comes to even how women respond and the side effects of treatment, Black people tend to even have more side effects compared to white people, and a lot of that is because when the treatment was being developed, a lot of it did not go through Black people at all. So we don't even have a good knowledge of how patients are responding or patients are reacting to treatment. And this is all due to underrepresentation. And this is one of the big things I've been clamoring about diversity in clinical trials. Also, Nigeria, there's a shortage of doctors generally, but not just doctors, oncology specialists. I think there are only about 90 clinical oncologist in Nigeria currently for a population of over 200 people, 200 million people. So you can imagine the deficiency in shortage of oncology specialists. And I'm sure it's the same with nurses, radiologists, across board. And because of that pressure, it leads to burnout and reduced quality of care that this people can give. So, what are the role of oncology nurses? Definitely, patient education is such a big thing. I usually say, teach one, teach all. So, I feel like patient education is so important. We provide culturally sensitive educational materials on breast cancer prevention, the symptoms, and treatment, and it demystifies cancer because a lot of times people are so afraid that they don't talk about it. But the more we talk about it, the less fearful people are going to become. When we talk about cancer literacy, it's beyond the letters, it's actually the mindset that we're talking about. Also, patient education would address myths and stigmas. I've had so many things. If you wear a black bra, you will get cancer. If you wear a bra that has iron around it, you will get cancer. If you use deodorant, you get cancer. There's so many myths. Oh, cancer doesn't happen to this, cancer this. There's so many myths. So addressing those myths and stigma in an open, non-judgmental way are where nurses come in, because nurses are the first point of call in a lot of places. And also, when people do have breast cancer and they're going through treatment, offering that practical advice on managing side effects of treatment, such as fatigue, nausea, hair loss, all of those things are very important. The big one for me is advocacy. Never stop speaking about better screening programs, access to care. When you hear that there is a screening somewhere, letting people around you know that this is available. I think for the World Cancer Day, NICRAT organized some screening programs in Abuja. When you hear about things, there are some other companies, Project Pink. There are people that do all of the screening awareness. Obviously, it's not regular, but when they do, advocacy, passing, disseminating that information around is very important. Also, making sure that you're supporting policies that address whatever systemic inequities that we see, participating in professional organizations like you're doing now, builds that bond. And then also support systems, connecting patients to whether it's financial navigators or social resources where they can access some form of help. And then a lot of places, like here in the UK, the nurses have been so instrumental in creating support groups. They speak to the patients, they bring similar people together, form support groups, and having that discussion between each other actually goes a long way for the patients. So it's something as nurses that you can think about in your hospital, get a few patients together, form a support group, help them talk about diet after, talk about survivorship, talk about a lot of things. Those are support systems that oncology nurses can help with. The one that I am passionate about as well is supporting research and data collection. So nurses are doing more than just clinical work. There's a lot of work that you can do as a nurse yourself. You can even start. You don't even have to wait. You can bring ideas, think about research, think about how you can collect data, because when you have data, you can show evidence. And from there, you can get grants, you can get a lot of things that can improve outcomes for the people that you treat. So, helping to identify trends, barriers, outcomes by putting all of this data collection together. You can collaborate with international research organizations, bringing to light what the unique challenges being faced by these women, and from there you can get help, you can get money, you can get support. So it's just one person deciding to say, you know what, I'm going to look at all the women with breast cancer that has come through our center, and you start collecting data. So it's a big thing that nurses can do. It doesn't always have to be the doctors, it doesn't have to be the students. So, what are some of the success stories we've heard? I mentioned Project Pink. There are a lot of grassroots campaigns that are happening. The social media campaigns. Like I told you, I've become a tele person advocating. You can set up something, TikTok, 1 minute information, pass it on. These are things that are successful that people are doing. And then obviously emerging innovations, people like us helping to bridge cancer gaps in care. And we've also had nurses from America and from the UK also joining into some of these tumor boards, giving some information. So last year, June and July, I was in Abuja and in Accra as part of the global health workforce, which included a lot of nurses. So doctors, nurses, radiologists. We went to Nigeria to talk about MDTs in, especially breast cancer MDTs. We went to Accra, you know. Somebody's writing on my screen. AC Okagbare, please, you're writing on my you're writing on the screen, so I'm not sure how you can do that, but please don't annotate on my screen. Thank you. I don't know how to clean this off, but anyway. The other thing that I want to bring to light is global partnerships, collaborating between other nursing oncology organizations. I don't know if Chinonso knows the Global Power of Nursing. So this is a big, big organization that have come together to address disparities. So you come together, you bring ideas, you share ideas, you go to conferences, they can sponsor some of your conferences as well. So you come together, you share ideas, you share knowledge. And then also by doing that, you can have training programs for oncology nursing. So you can get someone from the UK, someone from Pakistan, someone from another Malaysia, have a talk, train you guys. And from there, you can think, oh, this has worked in India. It could actually work in Nigeria. If we say, oh, UK, the US are high income, but there are other places that you can imbibe what they've done that works for them. So let's look at this case study. So, for example, a 40-year-old lady from Ibadan was diagnosed with triple negative breast cancer at the stage 3. Why did she come at the stage 3? Like I mentioned, a lot of it was due to the stigma and lack of awareness. She knew that there was something wrong, but she didn't think it was breast cancer. Also, she didn't have money, so she knew that she's always heard that breast cancer or cancer in itself is very expensive. But interventions by oncology nurses, they educated her about the importance of the treatment. They connected her to a local NGO that finally helped her with financial support. And also because she presented at stage 3, and it was triple negative, we know the biology of the cancer. There's a high chance that she might have a relapse. So it was important that a palliative care plan was put in place very early, even though her treatment was kind of curative. But it's all those things and interventions by oncology nursing. So, like I've said, nursing advocacy, very important, working with community leaders, school, churches, and other partnerships. The call to action is starting conversation. So I usually say, just start from where you are. You have a unique power, in your hands. Starting, don't think, oh, I need to join 200 people. No, start from where you are. From there, you can expand to other centers and come together. But even one person can make a lot of changes. And like I said, it's very important partnering with other international organizations, and I know that Chinomso have been very helpful in that regard, spotlighting a lot of people in that way and helpful. So I think it's really important. So conclusion is that breast cancer remains a significant health burden in Nigeria. Prevention, early detection, and advanced therapies can significantly reduce the mortality. And there are numerous opportunities available. And as oncology nurses, you are the heart of the fight against breast cancer. I will always say, like, my journey in oncology can never be complete without the nurses, because a lot of times the nurses take a big burden off us who are doctors. And we're hoping for a future where breast cancer will no longer be a death sentence for Nigerian women. Thank you. Like I said, I really want to hear questions from you guys. I want it to be interactive. So I haven't put too many slides on. And we can always have another webinar and talk about breast cancer and its management. So today it's not about breast cancer and its management, really. It's about highlighting what the problem is and how it can be helpful to manage that.
Thank you so much, Dr. Ayodele. That was quite educative and enlightening. You really touched on so many things, and we are sincerely grateful for your expertise. So we will take the question and answers now. If you have any question, just raise your hand, and then once we call you, you can unmute and ask your question. But please, we have to call you before you unmute so that it doesn't get too rowdy. But I will start the question session by asking my own question. Over the years in your clinical practice, how have you dealt with somebody having breast cancer and also pregnant at the same time? Yeah, because I know it's one of the issues we deal with, choosing between the pregnancy and breast cancer. And yeah, how have you dealt with that situation?
Thank you. So that's a really good answer. So, the management of breast cancer has evolved really, big time. So ages ago, if you had breast cancer and you were pregnant, most likely you need to terminate. But that has changed. So if, this was diagnosed less in the first trimester, so less than 13 weeks, actually, depending on how severe the stages or the level of the cancer, then we might have to discuss about termination of pregnancy. If it happens after 13 weeks, you can actually get chemotherapy. So I've treated a lot of patients who are pregnant with chemotherapy. The only thing we can give, so you can give anthracycline, you can give taxanes. The only thing you can give during pregnancy is trastuzumab. So if the patient has HER2 positive disease, then you will not be able to give anti-HER2 targeted agent during that time. However, if the diagnosis is like towards the end of pregnancy, so about 33, 34 weeks, then we try to get the baby delivered as soon as possible. So this is where collaborative effort comes in and MDT practice come in. So we speak with the obstetrician, we try to deliver the baby and the pediatrician. And because we're on this side of the world, we have neonatal services. Obviously, if it's in Nigeria, you want to monitor the patient until they're about 36 weeks and then deliver them before you treat. But you can treat at any time, apart from before 13 weeks.
Thank you so much. So which means there has to be a discussion between the provider and the patient. It's not it has to be the two of them that will have to discuss and determine the next line of action. Yeah, because most times when people have cancer, breast cancer or cancers and they are pregnant, they have to battle, okay, which one do I go first? And some people will say, oh, let me just stay on my own. When I deliver, I can go to the hospital. No, we encourage them to always go to the hospital, see their provider, and then they have that discussion.
Yeah, and also I have to mention that breast cancer in pregnancy is actually becoming very common. We're seeing it more and more. Also, not just in pregnancy, around pregnancy. So you've just had the baby, and then you're nursing. A lot of times you see the breast become red. You think it's mastitis, but it's actually not. I've had a few like that recently as well, where the GP was treating for infection and it wasn't infection, it was actually breast cancer. So we've seen a few of that. So if you notice any abnormality, even if you're nursing or around pregnancy, please go to your doctor and make sure that someone checks you out.
Thank you. Lawal's iPhone. I guess this is Miss Lawal. Over to you now.
Thank you very much, Mr. Chinonso, Dr. Chinonso, for this very beautiful initiative of creating awareness about how we can collaborate and improving our nursing responsibilities towards breast cancer patients. My question is around issues pertaining to mammography and breast ultrasound scan for a pregnant woman. I just want to know, how do you people which of the diagnostic methods do you choose? I mean, considering pregnancy, for people who are pregnant and they have breast cancer. I'm concerned because of the exposure to radiations and all that and the safety of the baby.
Absolutely. So, and this is why I said this patient has to be discussed in a multidisciplinary fashion. So, if one has or suspected breast cancer, there are two imaging modalities that we use. We use ultrasound and we use MRI because they're safe, you know, for the patient. The only problem we've encountered with those two is that you are not able to do a full staging. So if you find out that there might be lymph node involvement, so you can see during your ultrasound or during your MRI, you can see that, or even clinically, you can palpate lymph nodes, meaning that there's a high suspicion of lymph node involvement. The protocol is that you do a staging scan. But obviously, if she's pregnant, you can't do that. So that staging might need to wait till after the woman has been delivered. So we can treat when they're pregnant, but we tend to advise if it was near delivery to deliver first and then do everything so that we can have a robust conversation. But like I said, if someone presents 26 weeks or 29 weeks or even 14 weeks, which I've treated before with triple negative breast cancer stage 3, I'm going to push ahead and treat the patient, and assume that I'm doing a curative modality for the patient. If there is really bad nodal disease, then one of the things I can do as well, which I've done before, is I've done an MRI of the liver. I don't tend to do it often, but if you're worried, then you're thinking, oh, there might be, that you could do an MRI, or you could even do a whole body MRI. We don't do it very often, but those are things that can be done for the patient.
So, Ibrahim Yusuf, you are next.
Yeah, please confirm you can hear me.
Yeah, we can hear you loud and clear.
Yeah, thanks. So first, I'd like to thank the doctor, our resource person. Fantastic presentation. I mean, this can as well pass for, even non-healthcare workers. I mean, it's straight to the point, very elucidating. By the way, I practice in Nigeria. I'm not an oncologist, general surgeon by background, but I'd like to share two experiences. One, if you don't mind. One, I think there is still a lot to be done in the space of awareness, especially around so many things. I mean, around culture of belief. I've had a cousin's wife who passed on. I only got to know that she had a breast lesion. Between when I got to know she had a breast lesion and when she passed on was less than 3 weeks. And here was I, working a team where we've had quite a number of survivors, including the sickler. What more can anyone be asking for? Happening in Nigeria. But anyway, that's as an aside. But one situation that really stuck to me as a trainee was a 27-year-old who had presented, with obviously breast cancer. And guess what? Her journey started in one of our institutions. I wouldn't mention names. And then the doctor had evaluated her and had asked her to go and do, whatever, whether it was a FNAC or total biopsy or whatever it was. And the doctor simply just told her, go to the mortuary and do the tests. And hello, the doctor didn't exactly mean go to the mortuary. So it's a complex. The mortuary on the ground floor, the histopathology lab, and the pathologists on the top floor. But because the building had always been known as, the mortuary building, simply just told her to go to the mortuary. And it's like, go to the mortuary? What for? And that was it. She stopped going to the hospital. But then, of course, like our resource person did say, 24-year-old, more aggressive lesion. Before we knew it, things had escalated. So what am I getting at here? That compassion, that empathy, treats every patient like, she's your sister or she's your brother. Be very detailed, explicit in how you communicate. And I'm mentioning this because this is where our nursing colleagues really, really will play a significant role. I mean, a lot of doctors in Nigeria, they're under a lot of pressure, too many patients to see, and they don't have the patience to, be detailed in how they connect to the patient. But after the doctors have done their rubbish, I'm sorry to use the word, in terms of, the pressure they come under and they're not paying attention to details. This is where our nursing colleagues can take up from, like you explain. So that's just my comment I wanted to share. Thank you so much once again.
Very insightful, Ibrahim. I have to agree with you because here, when a patient comes in, the first thing they get is being assigned what we call a key worker. So your key worker is actually your nurse, and that key worker is with you from the time you walk through that triple assessment, whether you're diagnosed with cancer or not. But once you come in, and if you're diagnosed with cancer, they're with you all throughout. And it's so easy. So the nurses are actually our FBI agents because the patients tell them so much that they never tell us, which is why nurses are fundamental and they are core members of the MDT and they should be attending MDTs because when we're making decisions, the nurse will say, no, this woman doesn't want this. This woman, this is her social situation. This is her this. So nurses have way more bigger roles and I want you to see yourself as having a bigger role than whatever you think you have now. You're actually having and providing holistic care more than the doctors. If I have to put hierarchy of importance of healthcare providers, nurses come first, because you have that connection with the patient right from day one and they trust you more than they trust the doctors. So they will speak to you about the things that they will never tell the doctor about. So it's very important that you connect with the patient and they will likely listen to you more than they will listen to us.
Thank you so much for that response. So we have, if you don't mind, we have Odo Innocentia. I think you have the floor to ask your question now.
Good evening, everyone. Good evening, Ma. Thank you for the beautiful presentation. So my question is actually building on the first question for breastfeeding mothers. I want to know, regardless of the stage, will she still be able to breastfeed her child?
So it depends. So if it was diagnosed while she's breastfeeding, obviously she has to stop. If it was diagnosed during pregnancy and then she delivers, she cannot breastfeed, because the breast is where the problem is. So we're not going to advise her to breastfeed. So she won't be breastfeeding the baby.
All right. I think I can't see any other hand, but I have another question regarding genetic testing. It's one area we are not really doing quite well in Nigeria when it comes to genetic testing, especially for all these triple negative and BRCA1 and BRCA2 genes. I know a couple of patients. Well, they're not patients per se, but they just go for genetic testing because of their family history. And lo and behold, they had positive BRCA1 and BRCA2 mutation, and they had to do prophylactic bilateral mastectomy. But this is one thing that we have not really done very much in our Nigerian context. So maybe you could also add your voice to it. Yeah.
So, what can I say? So, genetic testing is such a big deal because of the stigma. We don't even have a family history. So that's one of the biggest problem that we found. We can't even screen people. So right now, we're trying to go into what we call precision screening, or based on your history, based on your age and things like that, screening people a little bit early. Because, for example, in the UK and in many places, screening is about 50 to 70 years old. But because we know that in Black people, things are different, we're trying to bring the screening age down. But because we don't even talk about the fact that people have cancer, we don't know the family history. So it's very difficult. And it's not only in Nigeria, even here in the UK and in the US, is a big problem because when you're asking for family history so that you can make genetic referral, you don't have it because people don't know. And the literature would say BRCA mutation is found in about 5%. But we've actually seen that in Black people, it's as high as 10% and more. And I feel like it's even more because we're not screening enough. Once we start to screen, like you said, Chinan, so we're going to find a lot of stories because you just have all the stories where you just say my auntie died or something, my mother's sister died, my uncle somebody died, but you don't know what it is. So it's important. I think at the same time we have to um, because resources are, we don't have unlimited resources. We have to choose our battle. So genetic testing is very expensive as well. So uh, if someone has money, the first thing you want to think about is management rather than, going to genetic testing. However, it should be something we should be thinking about and moving towards because it can help a lot of prevention. Like you said, if you've had your testing and you know that your family risk is there, then you can have preventive measures like prophylactic mastectomies, like you've mentioned, or even oophorectomies, because it can also be ovarian cancer and not just. You can also screen your male families because BRCA has been related to pancreatic cancer, prostate cancer. So it's not just breast cancer. And just to mention, men can get breast cancer. I know I've been saying women, women, women. We need to let our family know as well. Men need to check their breast as well. It's not as common, but it's possible. And because it's not common, by the time it comes, is usually metastatic, meaning that it's spread everywhere for the men. So men do get breast cancer, but it's something we should be, talking about. If there's a national cancer plan for Nigeria, obviously genetics should be big in it. I know that Marcel Root is trying to do some genomic screening with Yamachi as one of the studies that they're having. So it's something that once it gets running, that people can be signposted to and have some form of screening, genetic screening as well.
Awesome. And I think we have the last question now. Oluwaseun Martins Akinlose. Go ahead.
Good evening.
Good
From
evening.
here, Nigeria. My name is Oluwaseun Martins Akinlose. I appreciate you for today's awareness. I want to just share my little experience that happened just yesterday. I will start from the angle that thank God for the awareness that is coming up. We are not yet there concerning cancer, but we are moving. The awareness is increasing gradually. I happen to be a fertility nurse, and just yesterday at my place of work, I had a referral from, I was brought in by a patient, an oncology patient who has had mastectomy done, has had one section of, a session of chemo in the past. There was a reoccurrence, and she desires to have a family. Because by the time I started talking with her, luckily, I was so happy meeting her because I guess she met the right person speaking with her based on my experience, lived experience. So I was able to move along with her. So from a referral letter, she was referred to the fertility center to come and have her gametes preserved, meaning she will have to go through IVF, oocyte extraction, and to store for future purpose anyway, because she said she will be having chemotherapy very soon. So she was given referral to the fertility section of my place of work. So what happened was that I read through a referral, I realized she had female children. So I now asked, Madam, how many kids do you have? She said, I have 3. I looked at her face, I said, you're looking for a boy? She said, yes, because from our part in our Nigerian culture here, I don't want to state the particular tribe, they desire so much about males. So her intention is to have this male child before going for another section of chemo. So she said the intention is to have her egg preserved, and at the end of the day, not that she will carry the pregnancy, she's planning towards surrogacy. So we actually booked her. She'll be coming tomorrow anyway for consultation. What I want to bring out from the story is that awareness is growing up, technology is improving, and people are beginning to know that cancer is not a death sentence. You can still make many things get fulfilled in life with it. Just follow the trend. Make sure you, as nurses, that's our role anyway, because I was so excited meeting her yesterday. By the time we finished talking, she was so happy. She left with happiness in her. So our job as nurses, as advocates, we should please try and listen to the stories of this patient and then let them know that you have voices of hope for them as nurses, that when they see you, they should just have this peace in them and then put them through on what to do and what not to do. Thank you. Just sharing my experience.
Absolutely, and that's what I'm saying. Nurses, you guys don't know the strength you have. You don't know the power that you hold. Having that empathy and compassion and non-judgmental. Because as healthcare workers, people come to you in a state that you just want to say, "What the hell? What have you been doing?" But you have to hold yourself in and look at the bigger picture and say, you know what? Okay, she's come now. Thank God she's come. How can I best help? So it's really important. And a lot of patients, it's also empowering the patient to become an advocate. So when patients come to you, you're not just educating them, you're educating them to go back to their own community and become a teacher to everyone else around them, So it's really important. Well done. I like that story.
Yeah, thank you. And interestingly, the nurse that just made the comment now is a survivor, and she presented her story a few weeks ago on our platform. She's a board member of the Oncology Nursing Society of Nigeria, and she's using her personal story to drive change both in Nigeria and globally. So we appreciate her. Yeah. And then, we are having there are nurses who are also survivors or who are going through this case. And most times, it's difficult when you are a patient. It's easier to tell somebody else, but when you are involved in it, it's actually difficult to follow all these theories we've been talking about. So we encourage us to stand strong and also stand strong for our patient everywhere we go. And then, yeah. So since we have Obadan Adiola. Yeah. You have a question? Do you have time, Dr. Ayode? Do you have time for
Yeah,
more?
I'm here.
Okay.
I'm enjoying the conversation. So
Okay.
really, I'm enjoying it.
Awesome. All right, Obadan, over to you.
Good evening, Dr. Ayodele, and thank you for the very insightful session. So I'm sure you don't know how I got this link. Apparently, I have a cousin who is a nurse in Luke, and she sent it to me. So that I'll see your Dr. Ayodele is coming for a session. I said, oh, okay, let me join in. So thank you very much. Thank you for all the work that you do, trying to educate the Black woman to ensure that the outcome is improved. Now, I would like you to speak to a scenario where I love that the last person that spoke talked about you have nurses that have also been diagnosed or going through their own treatment, why they still need to kind of provide care for their patients. How do you respond to a nurse who kind of now creates a group and trying to encourage patients to try out alternative medicine, like you said? And because I've seen this happen, and unfortunately, because a lot of the patients also, some of them can't afford the cost of treatment and all that. And because they believe in the nurse, they say, the person is even a nurse, especially in Nigeria. You know the way, is a nurse that is even doing this thing. So she knows what she's saying. And she goes about telling people, you can use this, you can use that. And it's not as if, I'm not saying those things are bad or they are good, but I do not think that nurses should take that position. If anything, I think that nurses should encourage people to follow through their treatment so that the outcome can be from one source, so that you know that you're taking treatment from one source. But in a case where I'm a patient, for example, I'm taking medication from you, Dr. Ayodele, and then I'm behind the door, I'm taking another concussion or whatever. So if there is any side effect, you can't even trace it to where it's coming from, because you don't even know what this patient has been doing. And it is really heartbreaking that some nurses take advantage of this. They turn it to a business venture, and they put people in WhatsApp group, then telling them, take this, take that. And because these people are also vulnerable, they're gullible, they want help by all means, and they believe these nurses like they believe in God. What would you say to that? I wanted to speak to that, Dr. Adeli.
Gosh. So that it's a very difficult case, or it's a very difficult scenario, there are always going to be, I wouldn't say bad eggs, or people that want to take advantage of the situation. But this is why it's very important as an oncologist to have a really good rapport with your patients. So my patients, they know that my door is open all the time. Number one, that's number one. Number two, when I have that first conversation with them, I make sure that I'm highlighting things that are available, things that have been proven. So it's very important when you're going through treatment options for the patient to spell it out. Because when you don't spell it out is when someone else can come and trick them. Okay, that's one. Number three is you let them know that if there's anything you're confused about, come to me, because there's nothing you can do. How do I know someone who has set up a WhatsApp group? But if you have a good relationship with the patient, they would mention it at some point, or they'll come back and meet you and say, what, someone else came to meet me. What do you think about this? And then you can lead them right and say, There is no evidence, in medicine, it's so-called evidence-based, that one person had a good response to something does not mean it works. Even a bad clock is right twice a day, so it doesn't mean that it works. But what we have that is proven, that has been used in multiple people in different places, is what I'm giving you. So it's important to have that conversation and make sure that you, as that oncologist and that patient's doctor, that you have a good rapport, so that if any confusion comes up, they know they can come to you at any time for clarification. But there's
Thank you
nothing we
so
can
much.
do. There's nothing we can do about bad eggs. They are who they are.
Yeah, and I like that analogy that there are always bad eggs. And not only even in nursing, and sometimes some of these people they call nurses may not be nurses. Yeah, and that could also be a factor. There are also, even in the medical field, I'm not castigating. I just feel, yeah, we just have to create that rapport. When I did my PhD, I had to come down to UCH, I did an ethnography. So I studied everything that occurred in UCH, how they took care of their cancer patients and some of the cultural issues around there. And we realized that some patients will tell you that even oncologists will tell them not to continue their treatments so that they can come to their own private institution. And they may not have that resources. So I think it's a general thing that we need to be aware of. And when we see those red signs, we should be vocal to really go against them. Yeah, it's really pervasive and we need to stand against it. Yeah. And thank you so much. So, Khadijat, Jimo, you have a question?
Okay. Hello, Ma. Thank you so much for the wonderful section. I've learned a lot. So, I recently graduated from the Department of Nursing Science, University of Lagos. And while I was in school, I did a research internship at the NSI Lutz Cancer Center. So, I developed an interest in oncology nursing. And then there was a day I was speaking with a doctor, and he was like, which area would you like to specialize in after school? And I told him oncology nursing. So he said something that baffled me. He said I should write that date down, and then in 20 years' time, when I've become an oncology nurse, I should go back to it, and I would find out that I've saved 0 patients. Like, why would I want to specialize in an area of specialty where I won't be able to save life? And since then, I've just lost interest in oncology nursing.
Okay, so this is something I see all the time, and that's why I'm laughing, because I still had a conversation. So I was in Medilag or Unilag. I was in Nigeria recently, and I met with medical students, and we had this conversation because you see a lot of times we've talked. One of the things I mentioned is the shortage in healthcare, workers in oncology. Nobody wants to do oncology, but that stems from that fear of cancer being a killer. So that's what that person was saying. And it's important as oncology nurses that we need to start telling people that things are different. So let me use my own example. I had the same mentality before, okay? So when I was a medical student, my last year, actually not medical student, when I was doing my house job, because I did my house job in Lut just before I left, you go through a rotation, what is called a secondary rotation. And my secondary rotation was oncology. And we used to go home on Friday, leave like 4 patients on the ward, come on Monday, everybody's dead, So it was a horrible, horrible situation. And when I left the country, I went with that mentality because I was like, I want to do nephrology, I want to do infectious disease. There was no oncology in my head at all. But then my first internal medicine position was in Hemong. And I remember very clearly, this was the time that changed my life. My consultant said to a patient that you're cured of cancer. And my mouth literally dropped. And I was like, this is blasphemy. But thankfully, I did not hold it to myself. I went to meet her afterwards and said, I heard you say this person has been cured of cancer. Is this even possible? Is this a reality? And she sat me down and made me realize that early detection is key. If you get detected on time, cancer is curable. I use the word cure for my patients all the time. This is something that I would have never thought. I don't use remission. I use cure because they've been cured of their cancer. So times have changed. Even now, patients who have metastatic disease, meaning the disease that has spread, they are now living long. We're actually even curing some of those patients. I'm using the word cure again for cancer that has spread. Not just spread to bone or spread to lymph node. I'm talking of spread to liver, you know. So things have changed. We have better medications. The times of the old has changed. And you have a lot of oncology doctors, even in Nigeria, that have the same mentality, that think that the patient would die. So this is why we're doing a lot of capacity building, even in Nigeria, to try and reorientate the doctors that are working there, because they don't see, they're not used to the good stuff, because most of the time the people they see are like poor, the poor outcomes, or what they have to use. They don't have, the good drugs in quote. So, and that's one of the things I tell survivors in Nigeria. You need to be an advocate. You need to come out and start telling people and showing people the right stories, that people can actually survive this disease, because it doesn't have to be a death sentence. And that's why we as healthcare professionals, we need to start changing people's mentality and saying that this is why you need to check your breast every month. If you're having your periods, a week after your periods is the best time to check. You teach them how to check. If you've lost your period, put the first date of the month, make sure that you're checking. So this is our advocacy. This is how we change. So I'm so sorry, Khadija, that has happened to you. But please, oncology is such a specialty that you actually have impact and that you can make so much changes. That's been my own life. Like I'm on a mission, and coming into oncology, it's been so great. So please, don't let that conversation change your mind.
Thank you so much, Dr. Yadele, for reinforcing that. Yeah, Ekini Adebayo, what do you have for us? So after
Okay.
this, we'll take Ibrahim Yusuf, and then we'll call it a day, because Dr. Yadele has other. Yeah, she has a very tight schedule. To bring her on board was a tug of war, but we are very grateful she's here. So yeah, Ekini, you go ahead.
All right. Good evening, everyone, once again. And thank you, Dr. Ayodele, once again for meeting you the second time. So to the question that was asked by Martins, Oluwaseun, I think so, and expressing her interest and her concerns and all that. I want to mention something that I think during the presentation, the course of presentation, one of her slides, she made mention of the number of oncology doctors we have in Nigeria, about 90, and then nurses. I think she does not really have the figure for nurses, oncology nurses. Now, just like one of the hospitals in Nigeria, I know, I may not mention the name, a renowned hospital we know that managing the radiotherapy center they have. It is pathetic to know that in that hospital, you don't have an oncology trained nurse. And one of those years, when I was in a training, I think somebody mentioned it, that they have issues with nurses referring patients back to go to traditionalists and all that. Don't go to chemo, you're going to die. A lot of misconceptions and all that. And I told the consultant, the consultant of obstetrics and gynecology, I said, yes, those nurses will give you the same response, and then the outcome is what you see, because they're not oncology trained. In my center where I work, I have to give an example. My center where I work, If an oncology patient passes through an oncology nurse in the Department of Oncology, Radiation Oncology, that patient will not want to be nursed by another nurse who is not an oncology trained in another unit. If you send them to go, they'll say, no, please, I want to come to oncology ward. So I want to use this forum to make an appeal again and again. As advocates that we are in our different levels, whichever center you belong, please send a nurse, encourage a nurse to come. I remember when I was in school, when I came to do oncology, one of those days, I think my lecturer is on ground in this meeting. In fact, one day she was taking breast. I ran out of the class out of fear because I'm a nurse already, I'm a midwife. I ran out of the class out of fear. And another mentor now looked at me and said, what took you to oncology? What are you looking for? When you don't have joy, why can't you go back to O&G where you deliver a woman and you're happy at the end of it? You see your baby grow and you're happy. Mommy, this is the person that gave birth to you. He assisted you and you came to war. What took you to oncology? And I took a deep breath and then I said, sir, if you think oncology is end of life, but there must be somebody there at the end of somebody's life. And that is why I'm in oncology. You know, the thing shook that my mentor. He looked at me and said, you really have passion for this thing. Why are you there? I said, that is the reason why I'm there. If you think that it has come to the end of life, at every stage of somebody's life, somebody must be there. So I choose to be at the end of somebody's life if you think it is the end of life. So awareness is not just outside the medical field alone. Even with doctors, even with nurses, like the last person that just spoke, my last colleague that just spoke, that is a nurse, that when she was in school and all, the doctor said, mark today's date, and then the next day you now tell me that, yes, you regretted why you choose to be in oncology. Sincerely, there is joy in oncology. In this side of the world, I think we are more religious than other sides. We are very, very religious people in Africa and Sub-Saharan Africa and all that. So if you are looking for a place where you want to serve God in sincerity, it is oncology you will come to. Because it helps you to bend you, to strengthen you, to mold your parts and then make you who you should be actually in the field of medicine. I think oncology is one aspect of medicine that it humbles you, except you are something else, but oncology has to humble you to every extent. So please, if you come across a nurse who will tell you don't go for treatment, it is not an oncology nurse. Please. And so let us have it as we advocate for other areas in oncology, in the medicine field, or other things, or patients will get to know about what happens, about breast cancer, about every form of cancer, the awareness, the knowledge, and all that. Let us also advocate, even inside the clinical setting in the hospital, that look, you have to come and have a specialty in oncology. It's only when you come to the field of oncology you'll be able to understand the story we tell, be able to understand what is going on. So thank you very much.
Thank you so much. And that's why the Oncology Nursing Society is there to really help and motivate people to go into oncology specialty. And by the time we are fully functional, we are hoping to get grants and also funding so that we can also fund some nurses to go for specialized training in oncology. Yeah. All right. So Yusuf, are you on board? You are the last person that will talk before we call it a day.
Yeah, thank you very much for indulging me. I've spoken once. The comments was getting under my skin. I was getting very irritated about, the experience somebody had shared on this call. But you see, as the last two or three speakers spoke, I think I'm beginning to feel better about what some of our colleagues, do, whether nurses or doctors. For me, frankly, if we ever find a nurse or a doctor, who behaves in that pattern, that's completely unethical. I mean, you're moving someone to a field of care that you were not training. You don't even have any evidence to back it up. I mean, it's as far as I'm concerned, that's negligence, and that kind of individual should, should face the wrong. Now, I really love the comment from the last person that says, look, somebody has to be there at the end of another person's life. I mean, that's, for me, is a takeaway in this conversation. I mean, as healthcare workers, all right, we need to be able to give our patients hope. And even, I mean, we're humans too. There's a whole lot science knows. There's a whole lot medical science knows. But we also do recognize there's a whole lot more we don't know. But what singles us out is the fact that we're very open, we're very transparent, and we're very quick to say, oh, sorry, we do not know. And it should be that simple. All right. Again, it takes us back to empathy, which a lot of our colleagues don't have. Even if the patient is going to pass on, all right, there has to be dignity even in death. Thank you very much.
Thank you so much for that contribution. Yeah, and somebody was asking how we can get more training for oncology nurses. Yeah, I would encourage you to become a member of the Oncology Nursing Society of Nigeria, and we would always, provide information and as to where you can, get further training. We have schools of oncology nursing in Nigeria. I know most times it's funding and time, but if you join an association that fosters collaboration among nurses, that would also help us to understand where your knowledge needs are and how to meet those needs. So at this juncture, I would call Fatima Adam, the Vice President, to give the final vote of thanks.
Oh, wow, what a day. So, Dr. Olubukola, thank you so much for this. As in, myself personally, I see no other specialty that gives hope like oncology. Why? Because our patients believe they've already received their death sentence. So making someone that believe has received his or her death sentence, making them smile, making them laugh, giving them hope, it takes a lot. So oncology is everything you just need, because our patients, they are everything. And we as healthcare practitioners, as advocates, we don't only treat cancer, we treat the patients, we treat their family, we give hope. So on behalf of ONS Nigeria, I sincerely appreciate everyone for joining today's webinar. What's the big deal about breast cancer among Africans? A special thanks to Dr. Olubukola Ayodele for sharing her expertise and shedding light on the key challenges we tackle: stigmatization, myths, gender dynamism, and the underrepresentation of African in research, especially Nigerians, especially with the nurses. So your insights have been truly enlightening and inspiring. So as nurses, as advocates, we have a vital role to play, seriously, because the key point for me today is spelling it out. We shouldn't just wait until they are diagnosed, until they receive that death sentence they believe they've received, before we start spelling it out. We start spelling it out right from the community. Spell it out in the clinics. Spell it out when they are being diagnosed. Spell it out to them when they are on their sick bed. Spell it out even at the point of death, so that they will tell their relatives, see, they will be able to differentiate the right from the wrong. So we should keep raising awareness. We should keep advancing in our education and driving researches. We must also be part of solution by engaging in community outreach, embracing emerging innovations, and fostering global partnership to improve cancer care. So a big thank you to ONS Nigeria. Dr. Chinomsom, thank you so much for this, and the team for organizing this impactful section, and to all participants for your engagements. Together we can break the barriers and make a lasting difference. See you in our next webinar. Thank you, everyone, and have a good night.
Thank you so much. Thank you. Dr. Ayodele, I hope you won't be too weary to heed to our call next time too, when we call on you.
I really enjoyed it. It was everyone participated. I really like that, so because sometimes people can be quiet, but I like that it's engaging. So yes, I'll be back.
Yeah. Thank you so much. All right. So we will give announcement for our next webinar series. So just make yourselves available. We have a lot to learn. We have a lot to share, and then we'll continue to advance ourselves, improve ourselves for the betterment of our patients. Thank you very much, everybody. Bye now.
Bye.